not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He, got his wrist pain by doing over-aggressive high fives to his buddies.
Gosh, Vern, you trying to kill us all? Walking around all the time with that weed hanging out of your mouth? Don't you know how deadly that thing is? You're just asking for a case of the Big C, Cancer City, Chemotherapy Hotel. I care about you, Vern. That's why I'm warning you. You better give up them cigarettes, buddy, or the groundhogs will be bringing you your mail. Know what I mean?
All right, Vern, so today we're going to be talking about the ultrasound evaluation of dyspnea. This is a guide to using your ultrasound machine to approach your dyspneic patient in the emergency department.
What was Ernest's middle name?
Oh, I don't know. What was it?
I don't remember. Ernest something.
What was his last name?
No, I can't even remember that.
I don't even remember his first. I barely remember his first name.
It's a shame.
Ernest and Vern. Ernest died of cancer, you know that?
I didn't know that.
Lung cancer. That's why it's so appropriate for this podcast.
Interesting.
So dyspnea. So what are we going to use ultrasound to look for when it comes to patients with dyspnea? So we're going to look for the evaluation of pneumothorax, pericardial effusion, pulmonary edema, pleural effusion, pulmonary embolus, and a host of other things. But these are the main ones that we're going to concentrate on during this lecture.
Is that it?
That's it. So here's our classic disclaimer. The classic disclaimer basically says that we don't know what the hell we're talking about and don't listen to anything that we say because we'll help you kill patients. Something like that, right?
I don't think that's what it says.
It's pretty close. Okay. All right. So who does this right now? Who actually uses ultrasound in the evaluation of dyspnea? And there's this guy, I think he's somewhere in Europe. He's one of those European fellows, Daniel Lichtenstein. And Dan, I'd like to think of as sort of the lung king. And he's done a lot of publications in this journal called Chest. Have you ever heard of?
More of a pharaoh than a king you're showing there?
That might be a good point. Have you ever heard of Chest before? I don't know if you've heard of it. It's sort of a small journal. In any case, he likes to publish in this journal, and he published this pretty awesome article in 2008 where he basically uses an ultrasound. He goes into 301 patient rooms, and without talking to the patients or getting any other clinical information, he uses the ultrasound to diagnose why they have respiratory failure. So how good do you think he was, Matt?
I don't know. I think I would probably be close to 100% sensitive.
So he did pretty awesome. His sensitivity was anywhere from 81 to 97% with specificity of 95 to 100%, which completely blows my mind. So he's basically doing nothing but ultrasounding their lungs, and I think he also looked for DVTs, but just their lungs, and came up with these conclusions.
So no history. He didn't know these weren't patients that he was taking care of.
No, he wasn't attending in the ICU when he was doing this. I think this was all critical care patients.
So this was blinded, so he had kept his eyes closed the whole time he was doing this as well?
I'm not sure if he kept his eyes closed or not, but in any case, it's pretty impressive.
Right there.
Yeah, right. He could actually see the patients.
Check out the big brain on Brad!
So I guess the trick is that you're not necessarily Lichtenstein, so you might not be this good. So you might want to do some other things like maybe expand your ultrasound evaluation. You might want to actually look at the patient. You might want to touch the patient.
Wait a second. You just told me that ultrasound was like 90% sensitive. What's the sensitivity of my physical exam?
Oh, yours is probably 100, Dawson. So anyway, my point is you might not be quite this good, so you might want to put a little bit more effort into it.
Okay, so you're saying combine my history and physical with ultrasound.
Right. So my idea is that we actually use the cardiac exam, the lung exam, and the IVC exam, and those three things together we can help him get an impression as to why the patient is dyspneic. Make sense?
In 5 minutes?
Yeah, when you're quick.
Okay.
All right, so let's talk about this. So we're going to start with the cardiac exam. So I want to talk about what I consider the 2-minute cardiac exam. So we're going to look at 4 different windows: the parasternal long, parasternal short, apical 4, and the subcostal. And we're going to use all these windows to get our impression of what could be going on wrong with the heart. In the parasternal long, you're going to want to look at how good the heart's squeezing, whether the mitral valve's opening, look at the aortic root, make sure it's not dilated, look at the RV, is it big. In the short, we're really just going to be evaluating the size of the RV and whether that septum is flattened at all. In the apical 4, we're just really going to look at the size of the RV and if there's any valvular insufficiency. And then in the subcostal, really the only thing I want you to look for is effusion. So let's talk about that a little bit specifically here. So this is an example of sort of an augmented apical four-chamber view, Matt. And do you see anything abnormal in this heart?
Not really.
Exactly. So the ejection fraction is extremely reduced. It's got apical akinesis, so somebody's had a pretty big LED lesion
this
probably.
heart. I
Yeah,
thought you
yeah,
were
this
talking
one.
about
Yeah.
a different heart.
No, just this one.
Okay.
So this person has what looks like probably an LAD lesion, and then maybe even some circumflex lesion too, because they've got some lateral wall abnormalities
Well,
too.
sure, an LAD lesion. I thought you meant something significant.
Right, yeah, nothing significant. So this person's ejection fraction is pretty crappy. It's definitely diminished, and they don't have very good squeeze. So that's what I would want you to pull out of that image. Really, that's it. I mean, I'm not asking for anything else. There's some other findings on there, but let's just look at it and say, hey, that heart's not squeezing right. So in the next one, here's another one. Here's an apical four-chamber window, and this one also has an abnormality. Matt, do you see any abnormalities on this one?
I kind of feel like it's flirting with me.
It is flirting with you. Yeah, it might be winking at you.
Yeah, I see that.
So this is something called a McConnell sign. McConnell sign was used for a while as an echocardiographic diagnostic criteria for pulmonary embolus. And basically all it is if you see how the very tip of the right ventricle there on the left side of the screen is squeezing down while the rest of the right ventricle isn't squeezing, Matt likes to call that the apical wink. And it's also known as McConnell sign, and that's basically just where just the tip of the right ventricle is working, and it's usually occurs when there's an acute cause of right ventricular overload.
And I call it the apical wink. I think there should be more winks in medicine.
I agree. We should wink at least once per every diagnosis.
Yes.
Here's another window of an apical short chamber, short axis.
Is there a fish in that heart?
No, that's the fish mouth view. So that's looking at the mitral valve in the left ventricle. Okay. And then you can see this big, black, large thing sitting on top of the apical, or excuse me, on top of the left ventricle. That's actually the right ventricle right there. And if you look, you see that septum's pretty flattened. Does that mean anything to you, Matt?
Is there more pressure or volume in the
range? So if it's flattened the entire time, then it's actually pressure and volume overload. So this person has a big overloaded right ventricle.
Well, what does that mean, though? I mean, overloaded right ventricle, what does that make you think?
It makes me think of pulmonary hypertension. It makes me think of a PE. Sometimes you can get it from an ASD. But we don't usually talk about that too much in emergency medicine.
Okay.
So I'd be worried about PE, basically. Here's an example of this is a peristernal long axis with a pretty obvious abnormality. This person has a lot of fluid surrounding their hearts. They got fluid in the bag, which could very well be causing their dyspnea. So that's the 2-minute cardiac exam. So basically, four windows, you're looking for big obvious things. You're not looking for little subtle findings. You want to know, does the heart squeeze well? Is there any evidence of a PE? Is there anything else that could be causing the patient's dyspnea? So now we're going to talk about the IVC. So IVC can be a nice way to get a volume measurement on the patient, so an estimation of what their fluid status is. So sometimes if you think someone might be hypovolemic, their IVC would be flat. If you think they might be in heart failure, theoretically their IVC would be big and dilated. So we can measure the IVC, and we typically do that just distal to the first hepatic vein, where that vein comes off of the right heart. And I often do it in M mode. If you can't see the hepatic vein, you can just basically go 2 centimeters from the heart border and then put M mode through it, just like this. And you can ask the patient to take a sniff, or you can, if they're breathing fairly aggressively, you can just measure it and look at the differences in their respiration.
So where is your probe to get this view?
This is a subcostal long window, so it's basically like you're trying to get your subcostal window for your FAST exam, except instead you turn the probe 90 degrees. You're still pointing up towards the heart, but now you've got the probe marker pointed towards the patient's
so like just under the xiphoid, but you're saying the probe marker up to get this view.
Yes.
Okay, gotcha.
The American Society of Echocardiography recently published a consensus paper on the right heart sizes and measurements and things like that, and basically they came up with this particular criteria for measure or estimation of the CVP based on IVC size. So basically, small IVC less than 2.1 with a lot of collapse, your CVP is somewhere around 3. If your IVC is greater than 2.1 centimeters and it doesn't really have very much collapse at all, like less than 50%, then your CVP would be around 15 or so. And then if it doesn't meet either one of those criteria and it falls in the middle, then your CVP is going to be about 8.
So what does this mean if I didn't know what the word or letters CVP stood for? If I had no idea what that means, can I still use this, someone as unintelligent as myself? So let me give you an example. I have a patient come in short of breath. I'm not sure if I should give them more fluid or not. I don't know if they're in heart failure and they're overloaded and they have a lot of fluid on, or if they have low volume and their shortness of breath is from something else. I, in the past, have just taken the approach, I give them 2 liters of fluid, and if they crash and I intubate them, then I know they were probably fluid up.
That's probably a reasonable approach, Matt, but I'm not sure that it's the best approach.
Okay.
You're probably right, though.
Well, how could I use this IVC?
So I think what you're getting at is the principle of just looking at the collapse of the IVC. Is that what you're looking at?
Okay, so like if it was collapsing more than 50%, I would give fluid or wouldn't give fluid then?
If it's collapsing more than 50%, then your central venous pressure is probably pretty low. They need more preload, so you give them fluid.
But if it was distended and not collapsing at all,
they're probably not going to respond to fluid.
Then I would get another procedure out of it because I get to intubate them.
Right. So then you can charge more for their emergency department bill.
I got you.
Which is what you're looking for, right?
Okay.
All right. So here's how you can. This is how you can use IVC to get an estimate for whether volume is going to help your patient or not.
Tom, Kathy, I'm Dr. Stephen Poop. I'm sorry, there's absolutely nothing I can do for your son, but I can do the robot. That'll be $5,000. Good day to you both.
All right.
That video actually makes me feel really bad because I can't even do the robot.
So the lung exam. So this is the stuff that Lichtenstein is really known for. He likes to really look at the lungs with the ultrasound machine and evaluate for the presence of fluid in the lungs, for the presence of lung sliding, trying to figure out if there's a pneumothorax, if there's pulmonary edema, if there's a consolidation. So to do that, he mostly uses high-frequency probes, which you're seeing down here in the bottom 2 left images. Those are looking for the presence of pneumothorax. Sometimes he does use a curvilinear probe looking for B lines, which we see in pulmonary edema. So let's talk about that a little bit more. So when you're doing a lung exam, the way I typically do it is I get the linear probe and I'm going to put it in a longitudinal orientation just next to the sternal border, and you try to find 2 ribs, and you want the rib just sort of on the edge of your screen on either side.
So you're talking probe up and down, not side to side, right?
Yeah, up and down. So you're lying over 2 ribs at one time, basically. And then you basically look in between the ribs. You should see a really bright line. That's the pleural line. And typically from that line, you'll see A lines. Are these bright lines that run with the pleural line at equidistant depths from the pleural line, and then B lines are the bright lines that shoot up and down on the screen.
So the A lines go across and the B lines go up and down.
Yes.
Okay.
All right, hold on there a minute. Let's make sure we got this straight. So I take the linear ultrasound probe and I put it in a sagittal plane on the patient's chest. Now, I'm going to look under the pleural line, which is that bright hyperechoic line running under the ribs, and I'm going to assess for the presence of A lines and B lines. An A line, according to Lichtenstein, is a horizontal artifact that indicates a normal lung surface. Basically, all it is a horizontal line that is equidistant from the pleural line as the pleural line is from the top of the probe. There can be more than one of them. They can continue down in equal depths from one another. They're horizontal. They run in the same direction as the pleural line does. It's basically just reverberation artifact. All in all, not that helpful. The ones that are a little bit more interesting are the B lines. The B lines are comet tail artifacts. Now, these comet tail artifacts occur because there's interstitial edema, basically fluid in between those alveoli that's causing a bright line to go in a longitudinal plane at 90 degrees from that pleural line. They start at the pleural line and they run all the way down to the bottom of your ultrasound screen. That is a B line.
And the B lines, typically you'll see one or two there, not too many of them. If you see a bunch of them, you're worried about pulmonary edema, but just one or two actually just helps you confirm that there isn't a pneumothorax. So when you look at the pleural line, you want to look for movement at the pleural line. So we like to talk about ants marching. We like to talk about pleural sliding, but there's got to be some sort of change in the appearance of that line as the patient breathes.
So you said, you may get to this, but you said B lines make me think there's edema.
Yeah, but we'll talk about that in a minute.
Okay.
B lines are an artifact, and they signify edema. Here's an example, Matt, of pleural sliding. Do you see how that bright line right at the top of the screen, sort of in between the two rib shadows, there's what appears to be like sort of ants marching along that bright line.
It's kind of shimmering.
Yeah, it's sort of a shimmery. I like the shimmer term. That's nice. So that's sort of what signifies to us that the pleura is sliding on itself, and that the patient does not have a pneumothorax. And then you can do an M mode of that area, and you get something called the sandy beach sign. That's beach.
Got it.
And that's the whole principle there, is that M mode looks like waves crashing on a sandy beach. Like there's sand down there. I don't know. I don't really like that one very much, but we use it anyway. People like to talk about it. Now, if somebody has a pneumothorax, things are going to look a bit different, right? So you still see the ribs. You see the shadows from the ribs there, but then that pleural line, you don't really see that shimmering. You don't see the ants marching as much. And then on M mode, you get the stratosphere sign.
Whoa, like in space.
Like crazy, like Star Wars stuff.
So what is that? That's just, why do you get that?
You get that because so the ultrasound can't really see past the lung anyway. So everything you see past the lung is typically artifact. And if the pleural lines are sliding on one another, then you get that sandy appearance because it can actually see the two pleura sliding on one another. Whereas if there's not visceral pleura touching parietal pleura, then it hits that pleural line and then can't go through the air, so it just bounces right back at you. So you basically get the same thing repeated over and over again, which is why you get the stratosphere sign.
That makes sense.
Thanks. So here's an example of pneumothorax compared to not pneumothorax on just our B mode imaging. So which one there is the pneumothorax, Matt?
The one without the shimmering.
Excellent. The one on the left. Perfect. Here's an example of the two, comparing the sandy beach sign to the stratosphere sign. And you can see the sandy beach is on the left, so no pneumothorax over there, where the stratosphere is on the right, so there's evidence of pneumothorax there. The lung point is something that I learned about from Lichtenstein too, and he sort of uses this idea where he starts anterior with his probe, and he'll see a pneumothorax, and then he'll keep going lateral and then posterior until he no longer sees pneumothorax. And that point where he converts over from pneumothorax to positive lung sliding, he calls the lung point. And the theory is you can use that lung point and where it is on the patient's body to get an idea of how big their pneumothorax is.
So that's pretty cool because, I mean, we all know ultrasound is way more sensitive than X-ray for pneumothorax. But one complaint I always hear from people who are not all that big on ultrasound, usually because they don't just really get it all that much, is that ultrasound may be too sensitive. Can you pick up pneumothoraxes that are too small? But you're telling me you can actually kind of estimate the size of a pneumothorax?
Yeah, so think about it. So if your lung point is, so say you do your ultrasound initially right next to the sternum, and it's positive for pneumothorax, and then you start going laterally, and your lung point's like 3 centimeters away. That's a tiny pneumothorax, right?
Yeah.
But if you start going laterally and you get all the way down to the axilla before you see any sliding lung, that's a pretty big pneumothorax.
Okay, awesome.
So that's kind of how you can use the lung point. Here's an example of using the lung point there with M mode imaging, whereas if you're over an area where there's pneumothorax, you're going to get stratosphere, but then you keep moving laterally, or the patient takes a big inhalation, and you start getting some lung sliding there. So here's the B lines that we were talking about. So B lines are created by fluid in the interstitial space in the lungs. So what you get is you end up getting all these bright white lines that shoot down to the bottom of the screen, and those are comet tail artifacts is the name of the artifact that occurs. And it's basically just from the ultrasound beam just barely being able to bounce around in between all those air-filled alveoli in the fluid. And because there's more fluid in the interstitial space, it can bounce around easier. So more than 3 B lines per rib interspace is considered positive for pulmonary edema. Now that's in the anterior lung fields. Right, that's not the posterior lung field. So any normal person is going to have fluid in their posterior lung fields. But if you're talking about somebody who's sitting upright in bed and you look at their bilateral anterior lungs and you've got B lines in both of those fields, that patient's got fluid in their lungs for sure.
So how many B lines did you
3.
say? More than 3 in the anterior field.
3 or more, yeah, per rib space.
Okay, gotcha.
Ron, I know it sounds harsh, but God does not want her to live.
So that was
I hope we weren't talking about this sweet old lady on this slide.
not at all. But I love the fact that she's smoking a cigarette at the age of 100. That's the most awesome thing in the world for me.
Okay.
I think when you're 100, you're allowed to do whatever
Just
you want.
to be clear, I was very offended by that quote you just played.
Really? The Blues Brothers?
Yeah. Well, when you put it with this picture of this sweet old lady.
All right. So case 1. Here we go. We're going to do some cases to try to solidify all this stuff that I've been barking at you about. So
That guy looks really familiar.
yeah, I've seen him somewhere too.
Okay.
So case 1 is a 59-year-old guy with shortness of breath and chest pain. He comes in, he's got a history of COPD, he's got CHF, diabetes, your typical VA patient, right? He presents with worsening shortness of breath. You walk in the room, he's sitting up in bed, he's tripoding, he's tachypnic. He can only speak in like 2 to 3 word sentences, complains of some pleuritic chest pain, some difficulty breathing. You get some vitals from him. His heart rate's 104. He's a little tacky. His blood pressure's not too bad. It's 144/86. Sats are 72% on room air, so you throw him on a non-rebreather and they're 94%. So you do a physical exam because you want to try to impress your attending. And he's got some decreased breath sounds bilaterally. He's got some mild wheezes bilaterally. He's got increased AP diameter. Heart sounds are sort of difficult to auscultate, but you do notice that he's got a little bit of lower extremity edema and some JVD, but really you've seen worse. So what's your differential diagnosis on this patient, Matt? What are you thinking about in him?
Well, it's obvious to me that he has a COPD exacerbation or worsening CHF, or I guess pneumonia. Maybe it's an MI. Yeah, but it's one of those.
one of those huge, massively different things that you're going to manage completely differently.
Well, I told you what I do. I give them 2 liters. If I have to intubate them, then I figured out it's probably CHF exacerbation. If they get better with the 2 liters and antibiotics, it's probably pneumonia. If they don't get improved from anything, it's probably an MI. You just got to try some stuff.
What if instead of doing all that, you ultrasounded him a little bit?
Okay, whatever.
So here's his heart. So now you're looking at an apical 4-chamber view, which is on the left, right, and a peristernal long axis, which is on the right. What do you think about that heart?
I'm no echocardiographer, but it seems like it's not quite squeezing as much as it should.
Genius. So this heart is not squeezing hardly at all. This EF is significantly reduced. This person is in a world of hurt, right? So you look at this and you can tell just grossly that the heart itself is not squeezing very well. The ventricles are barely moving at all. When the valves open, they barely open. Like if you look at the aortic valve and that peristernal long axis, see how it sort of pops open for a second and then almost immediately closes? That's because the cardiac output's so low that it barely has to stay open at all.
Wait, so you said the aortic valve on the peristernal long. So
yeah.
The picture on the right.
Right.
With, the picture on the right, I've got on top the right ventricle, underneath that left ventricle,
right.
to the right of that right atrium, and between that right atrium and ventricle.
No, left atrium.
I'm sorry, left atrium and right ventricle is the aortic valve. That's what
right. That's the little 2 bright things that are flapping open a little bit there.
Okay.
So that's just barely opening. And then if you look at the mitral valve, which is the valve right below the aortic valve, that thing, that anterior leaflet, that one on top, should be really coming up and almost touching that septum every time the left ventricle fills. And if it's not, then you know that your EF is pretty low. In fact, there was a study done where they looked at how close it should come to the septum. And in that study, they found that it should be within about 7 millimeters of that septum. And if it's not, then your EF is pretty accurately less than 30%. So that's something I sometimes teach some of the residents and other people about whenever they're first learning echo. If you can't really get a grasp on, how good the squeeze is just by looking at the LV, you can actually look at the opening of your mitral valve. If it's not opening enough, then that's a pretty good hint.
So, I kind of spaced out there for a second. You said, tell me again, it's less than 30% ejection fraction if the anterior mitral
valve leaflet doesn't get within 7 millimeters of the septum.
Okay, I spaced out again on that sentence, but we'll move on. Hope everybody else got it.
All right, so then we look at the IVC. So we know the heart isn't pumping very well. We take a look at the IVC to try to get an estimation of the patient's volume status. We see a pretty big dilated IVC. I don't see a lot of movement there. You ask them to take a big inspiration for you or a sniff, and you don't see any collapse. So this patient's got a high CVP. It's probably greater than 15, just looking at this image. And then we take a quick look to look at the lungs to make sure they have some movement. I want to make sure they don't have a pneumothorax. And what do I see there?
Looks like some shimmering, so no pneumothorax.
Right.
A lot of the B lines, I guess I would want to know where on the chest you were.
Yeah, so I'm anterior on the chest in the upper lung fields.
So you told me that means there's a lot of fluid in the lungs.
Right. So they have a poor squeezing heart, a big dilated IVC, and lots of fluid in the lungs. So you still think it's COPD?
Well, I'll give them the 2 liters and find out, I guess.
So this is a case of cardiogenic pulmonary edema.
Oh, dang.
So close. So close. So pulmonary edema in these sorts of patients typically is going to manifest with a poor ejection fraction, like you see in that image on the left, B lines in your anterior lung fields, like you see on that image on your right, and then a dilated IVC. So the theory is these patients have pulmonary edema because they have some sort of heart failure. Typically, that's going to be left-sided failure if you're going to have pulmonary edema, right? And most of the time, we think about systolic heart failure. Now, you can have diastolic heart failure too, which we're not going to get into in this particular lecture, but you would expect if their LV's not squeezing well, then they've got backup of fluid in their lungs, right?
So all that's good and well, but I don't know if I have 30 minutes to perform these studies.
Well, I'm not sure it takes 30 minutes.
How long does it take?
Well, I think it takes 5 minutes.
Oh, really? Just to do... Well, I guess you're in the same spot, aren't you? Just moving the probe around real quick.
Yeah.
Peristernal long.
It's not like you're moving to a different room.
So this is just a couple minutes. This actually would take less time than me giving them their 2 liters.
Probably.
So it's actually a quicker diagnosis because I've got the machine right there. I'm doing it. And I'm not actually harming the patient.
And I'm telling you, you can diagnose heart failure on a patient using this particular protocol. I mean, I don't have any data to back this up, but without a BNP and without a chest X-ray, without everything.
Well, you said you don't have any data, but there is that. Isn't there that study looking at B lines versus BNP and academic?
Yeah, there was that one. That was a pretty good study.
Look that up. The B lines.
Hold on for a second here. Let me just go ahead and interject. So the study that Dawson's talking about is a study by Manson in Emory University, and William basically found that you could correlate sonographic B lines with an elevated BNP level. He did this by doing sort of a 4-zone approach using a linear transducer and evaluating for bilateral B lines on ultrasound, just like we've been talking about. What he found was that when there were bilateral B lines, that was correlated with a significantly higher BNP. In fact, that BNP averaged 1,500 with a range from like 1,100 to 3,700, which is a pretty high BNP. Now, when you compare that to patients who did not have B lines, he found the BNP averaged 530, ranging from 300 to 1,900. So there were some patients who had an elevated BNP without B lines. Now, is that inaccuracy of the ultrasound or inaccuracy of the BNP? I'll let you judge for yourself. In any case, he found a sensitivity of finding bilateral B lines on ultrasound whenever there's an elevated BNP greater than 500, and he found that sensitivity to be 33%. Now, that's not all that awesome, but what is awesome is a specificity of 91.7%. So that's a pretty interesting study that we're talking about here that Dr. Manson did down in Emory. So that's pretty interesting. But what I really want to know is ultrasound better than BNP? Can I basically use my ultrasound findings to diagnose CHF? And to answer that question, I have to look at a different study. I have to look at a study that was published in Academic Emergency Medicine in 2009. This study came out of Massachusetts General Hospital, and what they did is they basically created likelihood ratios for positive ultrasonographic findings of CHF and compared them to the likelihood ratio of a positive BNP. Their gold standard here being the final diagnosis of congestive heart failure exacerbation. What they found was pretty interesting. They found that if they used an 8-zone ultrasound approach and had 2 positive zones on each side, the positive likelihood ratio was 3.8. If they had a positive BNP, the positive likelihood ratio was 2.3. Pretty interesting. This study seems to suggest that maybe, just maybe, those ultrasound findings are better than those BNP findings. Now, that's what I like to hear.
This is awesome. So I can treat this patient appropriately after a few minutes of ultrasounding.
Yeah, you throw them on BiPAP, you give them some Lasix if their kidney works, and the best thing is you can repeat this. So you repeat this scan in 15 minutes after they've been on BiPAP. I'll guarantee you're going to see less B lines.
Guaranteed?
Guaranteed.
Okay. I'm going to try it.
Please, no more.
All right, so here we go. Case 2. So I don't know if you've heard this story before, but this is a 59-year-old male with shortness of breath and chest pain. He comes in, he's got a history of COPD, CHF, diabetes. He's got that shortness of breath, and you walk in the room, he's sitting up in bed, tripoding tachypnic, can only speak in 2 to 3 word sentences, complaining of pleuritic chest pain, and difficulty breathing.
Oh, you're not going to trick me. This is the same guy. He's got a CHF exacerbation.
No, it's not. It's a different picture.
Oh, okay.
So the heart rate's 104, the blood pressure is 144/86, his oxygen sats are 97%, or excuse me, 72% on room air, and 94% on a non-rebreather. So you do your physical exam. He's got some decreased breath sounds bilaterally, mild wheezes bilaterally, and increased AP diameter. His heart sounds are difficult to hear. He gets some mild lower extremity edema. He's got some JVD, but you've seen worse. So what's your differential, Matt?
This is the exact same case. You're not. He's got CHF exacerbation. We just had this case.
So you're going to do an ultrasound to make sure, right? You don't just want to throw this guy on BiPAP just because you've seen a case with a similar presentation, right?
No, that's how I practiced. The last case that I saw, I treated the same way.
All right, so anyway, we're going to do an ultrasound, and this time we're looking at some pretty similar images here. So we got an apical 4 and a parasternal long axis of the heart, right? And what do you think about these? Does this look like the same guy?
Well, it's not. No, it's obviously a different patient. The left ventricle is definitely squeezing better in this patient. Yeah, different patient.
Yeah, it's totally different. So not only is the left ventricle squeezing better, but like remember how we were talking about with the mitral valve not opening very well in the last one? Look at how well it's opening in this one and really like flapping up against that septum. So that tells me that in diastole you've got a lot of blood going into the left ventricle. So this person has a good cardiac output. They've got a good ejection fraction. Everything looks normal in this one. I would say this is a normal looking echocardiogram, wouldn't you say?
Sure.
Awesome.
You're the one that's passed the echo boards.
All right, whatever. So next we've got the IVC. So now we're taking a look at the IVC. We get a sniff. And what do we see when that patient sniffs for us, Matt?
It's collapsing some.
Yeah, so not super small and doesn't completely collapse on itself, but it's probably around 50% or so. I mean, so I'm not sure exactly what the CVP is on this patient, but it doesn't look like it's really overloaded.
Right, so this one isn't obvious. You said if it's distended and not collapsing at all, high CVP.
Right.
If it's collapsing completely, low CVP. I guess this is in the middle.
Yeah, I would say it's in the middle too. So I guess it's normal.
Okay.
All right, so we're going to go with normal. So we got a normal heart. We got a normal IVC. Why is this patient short of breath?
They're probably malingering.
Yeah, probably. All right, so now we're going to look at some lungs. So we got some vascular probe analysis of the lungs. And what do you see there? Was that some movement on the right side, but no movement on the left?
Is shimmering on the left. I do not see shimmering.
Yeah, I don't either. So no shimmering on the lungs, normal heart, and a normal IVC.
Spontaneous pneumo. I should have known.
Genius. So spontaneous pneumothorax, unless the patient has some underlying heart disease, I wouldn't really expect their heart exam to be that much different on ultrasound. Now, if they have tension pneumothorax, clearly it's going to be different because they're not getting any preload, right?
Okay, gotcha.
But pneumothorax is a cause for dyspnea without any evidence of tension physiology. I would expect it to look fairly normal in your cardiac ultrasound. The IVC really shouldn't look much changed unless there's tension also. So really the only thing you're looking for is just the absence of lung sliding unilaterally. And here we see that normal cardiac exam, the normal IVC, and then the big money winner here is that image all the way on the right, which is the pneumothorax, and you don't see any lung sliding on that particular image.
So this patient, you're telling me, the same presentation, but they don't need Lasix. That's not going to fix their pneumothorax.
Probably not. Big surprise, but I'm not
fluids.
sure if intubating them will fix their pneumothorax either.
Okay.
Radiation might, though, so you probably just get a CT scan.
Okay.
Yeah, just get a CT
that way
scan.
we can make sure, yeah, we'll see how big it is and possibly cure it with the radiation.
Good idea.
What's the matter?
Alright, so case 3, 59-year-old guy with dyspnea and chest pain. So he's got a history of COPD, diabetes, and congestive heart failure, presents with worsening shortness of breath. You walk in the room, he's sitting up in bed tripoding tachypnic, only speaking in 2 to 3 word sentences, complains of pleuritic chest pain, difficulty breathing, heart rate's 104, blood pressure's 144/86, oxygen saturation is 72% on room air, 94% on non-rebreather. Sound familiar?
It does.
Yeah, it's
Probably not. Okay. Yeah, probably not going to be the same thing, though, because you already tricked me once.
I already tricked you one time.
If I had to guess on a diagnosis of this one, I'd say infidelity.
So his physical exam shows decreased breath sounds bilaterally, mild wheezes bilaterally, increased AP diameter, heart sounds are difficult to auscultate, mild lower extremity edema. He's got JVD. You've seen worse. Differential diagnosis. It's still congestive heart failure. It's still diabetes, or it's still pneumothorax. It's still COPD. It's still pulmonary embolism. It's still pneumonia.
And infidelity. Is there such a thing
It's still
as
infidelity.
steroid-induced pulmonary edema?
Steroid-induced pulmonary edema?
Yeah.
That I don't know of.
Okay, never mind.
I mean, we kind of give it to the babies when they're born early, right?
But I mean, like huge
helps with
testosterone doses of.
I don't know. I mean, I've never gotten it.
Okay, good point.
So, what are we going to do? We're going to do an ultrasound. All right. So here's our apical 4 view, and then this time I threw a curveball at you and gave you a peristernal short axis. So the apical 4 is on the left, peristernal short axis on the right. What do you see, Matt?
That heart is so flirty. It's winking at me again.
Yeah, that one on the left does look like it's winking at you a little bit.
I gotta admit, I kind of like it.
So,
Makes me feel good about myself.
all right, so we see the right heart's big, it's dilated, it doesn't squeeze very well, right? Maybe the apex is squeezing a little bit, but the rest of the right heart does not look normal. What do you think about the left side of the heart? Does it look like it's filling really well?
I can't take my eyes off the right side.
The left side isn't filling very well, so it's almost as if there's something preventing blood from getting from the right heart to the left heart. Sort of strange. And then if you look at that peristernal short axis, the right side is huge. I mean, you got that right ventricle sitting on top. It's even flattening the septum of the left ventricle, as if the volume and the pressure in the right ventricle is higher than the left. Very unusual. So then we take a look at the IVC, and you know that IVC, what do you?
Looks big.
Yeah, it looks like a garden hose. That thing's huge, and it's not changing in size at all, right? So I'm going to go with an elevated CVP.
I guess, yeah.
We take a look at the lungs.
Shimmers.
I got some shimmering on the left.
Shimmering everywhere.
Got some shimmering on the right. So what do we think? All right, we got a big dilated right heart. We got a big IVC. I've got a left heart that's not filling very well, but looks like it's squeezing okay.
Something causing the right heart to strain. It's winking at me.
As if there was an occlusion in between the right and the left heart. You know, like...
What's between the right and left heart?
I think isn't there some lungs?
Oh, yeah. So, I don't know. Some sort of foreign body in the lungs?
So this is an example of a pulmonary embolism.
That makes much more sense.
Genius, yeah. So this patient had a pulmonary embolism. You can tell they had a McConnell sign. That's the winking that we were talking about on that cardiac exam. So there's the winking in your right ventricle. Big right ventricle, big and dilated. Small left ventricle. You can even see in that apical 4-chamber view that the septum is pushing into the left ventricle because the pressures are so high on the right. So this is not specific for pulmonary embolus. So this can happen in pulmonary hypertension. So don't just because you see this doesn't mean like this patient absolutely has a pulmonary embolism, but it can definitely guide you down that road, right?
So you're telling me if I'm seeing a wink, push lytics and ask questions later.
not at all what I'm telling you. What I'm telling you is this patient could just have pulmonary hypertension. So if you've got an old echo, it'd be nice to know if they had this in the past, right? Or is it something completely acute? I mean, if you see this in like a 20-year-old with no history of pulmonary hypertension and they recently had surgery and they've got a big inflamed leg that looks like it's got a huge clot in it, then I think if you're gonna make bets,
okay. So if your
you're
patient,
gonna roll the dice.
So if your patient is crashing, and you're trying to decide lytics or something else, then you're saying this could help.
So if my patient were crashing and they had this ultrasound, I mean, as long as they didn't have a contraindication, I would probably be pushing lytics.
Okay.
Just on the ultrasound. So that's where it becomes important for me, because I mean, pulmonary embolus. What do we really do? That we don't do that much anyway. You anticoagulate them, unless of course they're so bad that they need lytics, and in that case we do a lot, right? We make a life-changing decision.
Yeah, and if this is a patient that's crashing, this is not someone who we can send to the CT scanner for a PE exam, right?
Yeah, of course not. So that's when the echo becomes important. So those are 3 cases, and I don't know. Hopefully you got something out of it. Was that interesting for you?
That's amazing. I mean, those are cases that, with my 2 liters and see what happens strategy, they may not have done so well, but now you've given me tools to actually accurately diagnose. And you say this takes minutes?
Hey man, that's what I'm saying.
Wow, that's amazing.
All right, folks, get out there, ultrasound some hearts, ultrasound some lungs, ultrasound some IVCs. Let us know how you feel about it. All right.
And may the Schwartz be with you.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.